Good afternoon, everybody. Can you hear me okay in the back? Thumbs up. Okay, excellent. Well, my name is Georgine Hergenroeder, and on behalf of my co-chair, Dr. Sanders, and myself, we'd like to welcome you to this symposium. We are going to be focusing on pulmonary exacerbations and their management now in the era of highly effective modulator therapy. We are going to be examining this topic from a few different perspectives. First, we're going to be hearing from a person living with CF about their experience before talking about management of CF exacerbations from both an adult and a pediatric perspective. And then lastly, talking about how do we do decentralized studies to study treatment de-escalation in the era of modulators. And we'll wrap up with some Q&A at the end. So, without further ado, I'm going to pull up the slides for our first speaker. It is my honor to introduce Kaylee Alvarado. She is a Seattle local and a hopefully soon-to-be nursing student, and also a person living with CF.
Get situated. All right, good afternoon, everybody. I'm honored to be here today and to share my story with you all, particularly the part about how much my life has changed now that CFTR modulators have entered the chat. My name is Kaylee Alvarado. I am 29 years old, born and raised Washingtonian, and I'm living with cystic fibrosis. I'm living, I'm not just surviving, which is a stark difference from a few years ago. In order for you to be able to appreciate how far I've come, I first have to take you back to August of 1996. I was my parents' first child. I arrived a little bit early and seemingly healthy. Unfortunately, my parents only got to enjoy being new parents for a short while before I began puzzling doctors with an odd set of symptoms, including prolonged jaundice, concerningly low weight, and a noticeably junky cough. Things only escalated from there, and by 3 weeks old, I was diagnosed with biliary atresia and had undergone a Kasai procedure, which was actually done at CHOP. While the Kasai had been a success in terms of my liver health, I was still far from healthy. By 8 weeks old, I had required another surgery, this time for a severe bowel obstruction. Both operations had come and gone, but there was still no resolution of my two most concerning symptoms, which were failure to thrive and that stubborn, severe cough. The following months were a vicious cycle of doctor's appointments, unanswered questions, until finally I was diagnosed with CF at 10 months old. The answers my parents had so desperately wanted were here, but they were grim. At the time I was diagnosed, the life expectancy of patients with CF was bleak at best. My parents were told I'd likely only make it to my mid-20s, maybe my 30s if I was lucky. But regardless, it would be a difficult road. However, as would be the case with most parents, mine were not willing to take that news lying down. They did absolutely everything they could to keep me in the fight. This meant strict adherence to my daily treatment regimen, my medication regimen, all while juggling work, family, and their own well-being. It was a ton of work, but it paid off. It wasn't long before I started resembling an almost one-year-old, and my once junky cough had become less and less so. Fast forward a few years, I was an energetic kid who was in most respects normal. Maybe kind of weird, but normal, physically. I went to public school. I had sleepovers with my friends. I played sports, I watched TV. With the exception of treatments and meds, and always being among the smallest of my peers, I had a pretty typical childhood. It wasn't until 7th or 8th grade that I was hospitalized for my first CF exacerbation, which I remember being told was quite remarkable given my diagnosis. Quick sidebar for those who might be unfamiliar, a CF exacerbation is essentially an acute worsening of respiratory symptoms that results from a spike in the amount of bacteria in a patient's lungs. Most exacerbations require some version of antibiotic treatment, either oral or IV, depending on the severity, as well as an intensified treatment regimen, plenty of rest, as much movement or exercise as you can tolerate, and as many stomach calories as you can stomach. The fewer exacerbations, the better, as they also cause long-term permanent damage like scarring and loss of lung function. My first tune-up, that's the nickname for the IV therapy, albeit scary, went relatively smoothly. My lung function popped right back up to baseline, and I went about normal life once I was discharged. I wasn't admitted for another year or so, and this was a pattern that continued well into high school. By sophomore or junior year, tune-ups were becoming more frequent, and I'd lost a little bit of lung function, but all things considered, I was still quite healthy. Senior year came and went, and by the fall, I had moved into the dorms at Boise State. This was my make-a-wish was actually to have my dorm decorated by someone from HGTV, so that was pretty cool. I didn't know I qualified for Make-A-Wish until I was just about to turn 18, so that was cool. My freshman year of college was awesome in pretty much every regard, except for my health. Having such a high maintenance illness got the best of me. My lung function dropped from about 85% to 50% in the space of a few months. I still remember seeing that number on the computer screen and just refusing to believe that it was correct and reassuring myself that it must be the machine. But after a few more trials yielded the same result, I kind of accepted that that was probably my new baseline, and I was not invincible. I finished off my year, soaking in every second, knowing that I probably wasn't going to be back for a round two. I returned home feeling angry, frustrated, tired, and depressed, foreshadowing of the downward spiral I would find myself in over the next 4 years. Exacerbations became more and more frequent, averaging at least once a quarter. The sheer amount of coughing I did on a daily basis was exhausting. It would cause just excruciating pain, and I was quite literally drowning in mucus. My weight dropped so low that I needed to have a feeding tube placed. My social life was practically non-existent, let alone my dating life. And it seemed the harder I fought, the worse things got. It was 1 step forward and 10 steps back. The final twist of the knife came when talks of transplant began. I was 20 years old, and I was contemplating whether I should pursue organ transplantation or accept that I was probably going to die even earlier than I was told. So I felt very defeated. But don't worry, it gets better. Fast forward to November of 2019, November 23rd to be exact. A new miracle drug called Trikafta had finally been approved, and it was in my hands. I had been able to take Trikafta's 2 predecessors, Orkambi and Symdeko, but I didn't benefit greatly from either, so I was cautiously optimistic about this one. I tossed back 2 unassuming orange pills with an eggnog latte that I'd made, and I prayed. Within hours, I didn't have time to grab tissues. I just started noticing these undeniable changes. I was coughing up literal handfuls of mucus. This continued for about 48 hours, and it was exhausting, but it was amazing. I also kept thinking to myself, I was like, man, there's no wonder it was so difficult to breathe. This is what was down there. And I was just amazed every time that it happened. It was never ending. And then came the really good part, which was just a whole lot of nothing. I had no cough, no crackles, and deep sleep like I hadn't experienced in years, the ability to lie flat, not propped up like I'd grown used to. And I also had the energy of a kindergartner who just drank 10 shots of espresso, and just an insatiable appetite like I'd never had before. It was just awesome. And then it just kept getting better. Significant increases in lung function and weight, the ability to get my feeding tube removed. That one makes me emotional because that was really a huge triumph. All my transplant-related appointments canceled. Victory after victory, and I just kept waiting for someone to pinch me. Flash forward to today, I'm not just surviving anymore, I'm living. Met the love of my life. I'm getting married next June. I decided to start pursuing a career as a nurse, both out of passion and out of desire to help others in the way that I've been helped so many times before. I've also become an auntie 4 times over to siblings' kids and friends' kids, and I'm raising 2 kids of my own. That's Winston, the dog, and the iguana's name is Greg. Doors I thought were closed for good, like world travel, retirement, those have crept back open, and life is finally good and normal. Maybe too soon. I've since started on the newest CFTR modulator called Aleph-Trek, and while it wasn't as much of a home run as Trikafta was for me, I'm still very grateful for it and the brilliant minds that brought it to fruition. I dream of a day when CF is a distant memory for everybody affected, but until then, there is still work to be done. About 10% of CFers are genetically ineligible for any of the current modulators, and even if they were eligible, modulators are simply not a cure. Every person in this room, from doctors to researchers to dietitians and social workers, CF Foundation representatives, patient advocates, we all have a role to play. To each and every one of you, I want to say thank you from the bottom of my heart. It's because of you and your commitment to ending this thing that I'm alive today, and that the younger generation of CFers is going to walk a much, much smoother path than I have. Thank you. Oh.
Wow, Kaylee. Thank you for sharing with us your incredible story. We have the chance for about 5 minutes of questions now, if anyone had questions for Kaylee, before we move on to our next speaker. And you're also welcome to ask questions through the app.
Maybe, well, I don't know if somebody's come up, maybe I can ask a quick question just about, we talked about kind of the increasing pattern of being the tune-ups and how do you feel about symptoms now, or the use of oral antibiotics, just fitting with the theme today? Just, is a cold just a cold, or, how does it compare?
So I think the biggest difference that I've noticed post-Trikafta or post-modulator has been, like cold can just be a cold this time, now. And it'll still spiral into something worse every now and then, but there are times where I'm able to get over it faster and with more ease, and not have to worry as much about it spiraling out of control. So, yeah.
Hi, Kaylee. First of all, thank you so much for sharing your story. You made me cry. You were crying, I was crying, we were all crying. Your story is amazing, and I'm so happy for you. As a social worker, as part of the CF team, I have lots of conversations with young adults about how wonderful these modulators are because it gives you more life, more quality of life. I'm wondering if you don't mind, and you can say no, talking about the difficult parts of now being given this opportunity to get married and have a future and thinking about what that's like and what can we as care teams do better to help people like you cope?
That's a really good question. The first thing that comes to mind, and I think a lot of people my age who were born around the same time are probably having similar thoughts, and that's, what do I do about retirement? Because that's not something we ever thought about before. And it's exciting. It's like really incredible that, you know, it's even something we're having to think about. But yeah, figuring out how to balance health, staying healthy, and working enough to, you know, be able to retire someday, and just, yeah, kind of navigating that for the first time because it's sort of uncharted territory for all of us, caregivers and patients alike. So I think that's the first thing that comes to mind. And just kind of as far as suggestions on, you know, what caregivers can do or providers could do to help with that, I don't really know. But you know, over the next, I don't know, 5, 10, 15 years, once, you know, people are living even longer and longer, hopefully that'll kind of unfold and things will become a little bit more clear on, you know, what a good path for a CFer to take is as far as like planning for retirement.
Thank you again, Kaylee. So it's my pleasure to introduce the poor speaker who has to follow that up. So our next speaker is Chris Goss. Chris is a professor in the both medicine and pediatrics at the University of Washington. He's associate dean for clinical research in the School of Medicine at UW, and as well as the co-executive director of the TDN. He'll be talking to us about pulmonary exacerbations in adults with CF.
Well, I want to thank the moderators, and I want to say that Kaylee, it's actually really daunting. I followed a lot of people speaking, and this is the toughest ever. That was the most wonderful talk I've heard in a very long time, and thank you for sharing.
I appreciate it. Thank you.
I almost like it's for Monty Python, now for something completely different. But here are my disclosures. I won't go into them. I don't think they affect the content of this talk. But I'm trying to sort of take us back to where we were. This highlights a paper from 2009. But treatment with exacerbation is usually antibiotics, chest PT, oxygen, mucolytics, steroids, bronchodilators. And we did an old systematic review. This was led by Patrick Flume and we published it in 2009. And only 2 questions received a grade of B. Everything else was poor evidence, which was continue use of chronic therapies during exacerbation and use airway clearance during exacerbation. And that was it. Everything else received insufficient evidence or extremely poor evidence. I think we can now say it's starting to change. So there's a program I'd like to highlight, which is the Standardized Treatment of Pulmonary Exacerbation Program, or STOP program. And this is a program that, and I actually realize I've left off one important one, but I'll get to that. But we started with an observational trial, and then a large interventional trial, and now we're doing what's called STOP 360, which is a platform trial. And these tested duration of antibiotics. The current one is testing 1 versus 2 IV antibiotics for Pseudomonas. And maybe there'll be future trials in the system, but I omitted here the STOP PEDS, which is the pediatric trial, whether we can avoid antibiotics entirely, oral antibiotics for mild exacerbations. This was the STOP 2 design. It was fairly innovative, and the design is based on a lot of input from patients. So we wanted to evaluate the efficacy and safety of different durations of IV antibiotics, and we enrolled adults who received either home or hospital-based IV antibiotics, and they got a standardized antibiotic treatment guideline. But patients were seen at visit 1, which is the beginning of the exacerbation, and then they were evaluated at 7 to 10 days. If they had a large improvement, we randomized them to either 10 or 14 days of duration. If they had a small improvement, then we randomized them to 14 or 21 days. And it was a large study, 57 sites around the United States, 1 site in Canada, and this is enrolled from July 2016 to January 2020. It finished just before the pandemic. But after Trikafta, we had about 2 months of Trikafta. There was over 1,000 patients screened, 982 patients were allocated to different treatment arms, and we had 277 patients were in the large improvement and 700 the smaller improvement. So that was the different 2 arms. But just to remind everyone, this showed the difference in outcome of lung function. This is the 10 versus 14 days, and this was termed a non-inferiority part of the trial. 10 days had to be not inferior to 14. And as you can see by this general graphic, they actually are very, very similar. And then we looked at the 14 to 21 days, and 21 had to be superior to 14. And it turned out 21 didn't really add much benefit. It was not superior to 14 days. So this suggested we could actually start to provide some evidence about how long we treat exacerbations that are IV treated. We also want to know, did they affect the time to next exacerbation? And this is because some of the key evidence that we use to treat with 2 antisomal agents was that the time to next exacerbation would be earlier if you did not include aminoglycoside, particularly tobramycin. And it turned out that shorter durations, shortening the duration from 10 or 14, this time to next exacerbation was about the same. These are survival curves with pulmonary exacerbation-free probability on the y-axis and time on the x-axis. And you can see these are sort of very superimposable curves. So there really was no change in the time we do next have an exacerbation. So what did we conclude from this study? Among those with the early robust response to IV treatment, 10 days was not inferior to 14. For those with a less robust response, 21 was not superior to 14. But you really couldn't infer equivalence from 10 to 21, and that's because the populations were different. So that's really an important take-home point. It doesn't mean everyone can get away with 10. It only means that those who had a robust response by day 10 could actually get away with a shorter duration. Adverse events were very rare and did not differ between the treatment arms. So what else did we learn from this trial? Well, it's a very large randomized controlled trial. We could do lots of subset analyses of the data. We compared patients treated at home versus those treated in the hospital and it turns out treatment in hospital was associated with better lung function, better symptom recovery, and better weight improvements. Also importantly, greater than 1/3 of all the patients in the trial were treated for pulmonary exacerbation tested positive for respiratory virus during the presentation, and were more symptomatic initially when they had respiratory virus, but had limited impacts on the long-term outcomes. The also important note was empiric physician-directed treatment of systemic corticosteroids, although common, wasn't really associated with an improved outcome. And lastly, these are very costly events, $61,000 to $75,000 per event. This is often under-acknowledged by physicians and care providers, so these are still very important events. But what about modulators? Because certainly things have changed. Well, we were able to look at the old classification of modulators, and this is a paper from Dr. Ali McElvaney looking at the impact of modulators within the trial. And lung function on this A panel suggests that lung function response was the same whether you were on modulators or not. And this would be lumacaftor, ivacaftor, or tezacaftor, ivacaftor. The same with symptom score, and symptom score is this change in the CRIS score that has nothing to do with me, that's the chronic respiratory infection symptom scale. And again, the response was about the same whether you were on these drugs. So if you needed IV antibiotics, your response didn't matter based on your modulator status. However, And we also have some additional evidence from the ivacaftor trial, which suggested the response to getting your lung function to better than it was at the beginning, meaning almost 100% or more response to treatment of was similar between placebo and ivacaftor-treated patients. So even though the ivacaftor-treated patients had many fewer exacerbations, their response to the actual event was fairly similar. But again, with the approval of ivacaftor, as noted by our prior speaker, a 63% reduction in pulmonary exacerbations. And really, this was quite profound. And that was all pulmonary exacerbations. This is the graph from the Middleton paper in the New England Journal in 2019. Exacerbation leading to hospitalization, and pulmonary exacerbations true with IV antibiotics. So this was really a remarkable change. And many of us noted this all at once. Suddenly, our hospital no longer had CF patients being admitted for IV exacerbation. It became quite a rare event. We wanted to know, two events happened though at the same time. As Trikafta rolled out, it was also the pandemic rolled out. And so Dr. Ann Stevenson and I and a group wanted to know how much of the drop in exacerbation rate was due to the drug and how much was due to the pandemic. And interestingly enough, the drug was approved much later in Canada than it was in the United States. So broad access to Trikafta was almost 2 years delayed in Canada. So this is a graph. It shows the exacerbation rate per month. I say it's per 6-month period. Blue is the United States. Red is Canada. These are the two, is a merged registry data set of both Canada and the United States. And so exacerbation rate was going down prior to the advent of Trikafta. It was slowly going down. And then it had a precipitous drop. The United States exacerbation rates per month went from 6% to 1.3%. That was a 4.8-fold drop in exacerbations, and that's what we noted right away. In Canada, it only went down from 4.3 to 3.1. And then when Canada got Trikafta, it went down further from 2.9 to 1.4. And doing some fancy math called the differences in differences, we know that the Trikafta effect was probably about 2.7-fold reduction, not quite the 4.8-fold. So they're still happening, and the effect was probably augmented. It's what we were feeling clinically by the pandemic because people were in isolation. And this is just a graphic of the rate at which patients get IV antibiotics in the CF registry. So this is Sonia Helshi at the TDN Coordinating Center created this graph. This is the percent of patients on CFTR modulators versus no modulator. And this is before and after. It takes us through 2020, 21, and 22. And you'll see that about 70 to 80% of all exacerbations are still in modulator-treated patients. However, the absolute number is much less, roughly about 4,000 a year compared to almost 12,000 a year. Now, what happened to the duration of treatment? You know, we'd done this big study. The CF Foundation has supported this very important study. So what happened? Did physicians listen to the study results? Did they change their practice? But the problem, again, Trikafta came at the same time. So it turns out that during this period after 2019, the duration of IV treatment had decreased by 2.2 days. And the confidence boundaries go 1.9 to 2.4 days. And the criteria for exacerbation we use in the registry, you got to be IV-treated exacerbation between 2016 and 2022. And then you had to have less than 48 days in total of IV treatment. And you had to be 18 years of age. So again, it suggested that actually duration was coming down, and it continued as the pandemic was waning. If you divide it between those on modulators and those without modulator use, there's a little greater decrease in the duration in those on modulators, that's the orange graph, versus those who are not on modulators. But still, we seem to be able to decrease the duration without significant impact on the number of exacerbations. And this was adjusted for sites that participated in the clinical trial, also for the center size, and also, but they were a majority adult centers. But this is just an idea of what's happened since the top study was published. IV duration in 2016 went from 14 days now to 2022 is about 2.8 days. So that's probably a meaningful change. We haven't redone the analyses for 2023 and 2024, but we'll see if it continues to decrease. Hospital days have also gone down. So how do providers feel? Well, I think we've just heard what a patient feels, which is miraculous. Providers, this is a great study, a really timely study published in the Journal of CF in July. I think it really it expresses exactly what I feel as a provider. They did 19 qualitative interviews with 15 CF centers, and everyone says pulmonary exacerbation has changed. Providers feel less anxious about the outcomes of pulmonary exacerbation, and persons with TF are really started driving their care during pulmonary exacerbation more. And providers are expanding their assessment of pulmonary exacerbation. And last, the provider management is less aggressive. And I felt this in my own clinic. It's very challenging when you go on through the era that many patients went through to think about getting IV antibiotics a day, today, now. And I've certainly taken out, I don't think I put any ports into my patients, but I've taken out a lot. So there are a lot of changes that have happened in CF with Trikafta. And patient management includes, I think, may have changed, meaning that also include non-pulmonary complaints like weight loss or fatigue. There are probably subtle sub-phenotypes of exacerbation and less aggressive management. And we have a little data to support that. We did a single center study. This is from courtesy of some statisticians here at the University of Washington. We wanted to look at what providers at the University of Washington, there are 5 CF providers, what the natural history of oral antibiotic use for respiratory symptoms. And we wanted to look before and after Trikafta's introduction, and including the period of the pandemic. And we used this data called EPIC data, which is electronic healthcare data. There were 376 modulator-treated patients in the adult center. And we studied first the uptake of Trikafta or ETI. The share of patients prescribed ETI was 0% in October 2019, and then rose quickly to 40%. And I think our current rate is something like 93% in our clinic. But what happened to oral antibiotic use? So this is 82% of our patients received an oral antibiotic during the time interval. And this would go along with my entire career of CF. There's a very well-known paper, which I often quote, which suggested clinics that used more antibiotics had better outcomes in their patients. It's probably everywhere else you study antibiotic use, more antibiotic use does not necessarily be better outcomes. But in CF, it seems to. And here in red are in dark red are the total prescriptions, in blue are the individuals prescribed antibiotics. So you can see the curve goes up, and our clinic is sort of increasing in size. The pandemic, the ETI is approved, it starts to go down. The pandemic hits, it continues to down, and then it really bottoms out. And then since that time, we sort of have crept back up with the use of oral antibiotics. And there's some seasonality in here. I can tell you a very fancy analysis has suggested that actually we're back to our same level of use of oral antibiotics as we were prior to the end. Now, this doesn't include IV antibiotics, but it's food for thought of what's happening as we're now in 6 years after the approval of this drug. But they still are occurring. And this is data we took from our centers that are involved in the Stop 360 study. In the blue bars are patients with Pseudomonas and IV pulmonary exacerbation by site. The little bars are those of the patients enrolled, but what you can say is some centers still have 50 IV treated Pseudomonas exacerbations per year. So large centers still have events that are occurred. And again, I think the prior data suggests they still happen, and they still happen in particularly large centers, a significant number of events. But how have they changed? And so we went back and we compared the patients who enrolled in Stop 2 to those that are enrolled in Stop 360. And again, Stop 360 is on the left-hand column here. We'll see if we can point. There were 785 patients who were Pseudomonas positive. About half were female. Stop 360, we have a little higher rate of baseline of patients who were female. And then of those on highly effective modulator therapy, or primarily just Trikafta, 58% of them have been on Trikafta. The mean age, they're about the same. And then if we look at where their lung function is, and this is a graph of categories of lung function, they actually have better lung function. There are fewer patients with lung function between 25 and 50% predicted who are enrolling in the trial who are getting IV antibiotics. And again, more people who have better lung function, between 75 and 100% are predicted. And again, modulator use in the STOP 360 study is actually now quite high. So the patient population seems very similar, but maybe a little better lung function. But interestingly, greater than 10, this is a graph that was produced by the statistical staff, the coordinating center. This is the percent of patients, the proportion of patients with greater than 10% drop in FEV1. And the little blue dot, the sort of this dot shows the STOP 2 study, and the large blue dot is the STOP 360 study. And so more patients are now presenting with greater than 10% drop in lung function, more patients having adventitial breath sounds, so crackles on their exam. And this is really, I thought it would be flipped. I was convinced it would be flipped. And we'll see if this stays this way through the trial. And then actually more patients have new lobar infiltrates or atelectasis. So some of those factors suggest more severe exacerbations, and maybe we're using oral antibiotics hoping not to do IVs. And that's why patients are presenting a little more advanced in their symptoms. So what would I say? I said, although reduced IV exacerbations are clearly still occurring, but utilizing a shorter course is probably effective. And whether this is the STOP 2 effect or is this Trikafta effect, I don't know. Providers are really challenged with exacerbation decisions in this new era. I think our decision to start treatment is confusing. I think patients are clearly going to be reluctant. I would, if I'd gone through the prior era and I'd been doing well, to go back to those other days. I would, and it can be very traumatic for a patient who's been doing well to now say, I have to go to the hospital and get an IV. Yet, at the same time, for those enrolling in STOP, I think clinical presentation seems to be a little more severe, even though their lung function's better. So I think there's still a challenge in our CF care. Fortunately, not the challenge they were, and I hope that continues for a very long time, but I think we still have work to do. So I want to acknowledge the funding. All the STOP program has been funded by the CF Foundation. Bob Bell helped early funding. Preston, Mike, Bruce Marshall was a big champion, and JP Clancy has been cheerleading us with STOP 360. And also the patient and families who participate in these studies and all the STOP sites and PIs. And these are some of the institutions represented by the STOP team. We're a big team of leaders, and we've hopefully will continue to advance our understanding of how to best manage patients in this new realm. So I want to thank you for your time, and I'm actually on time, which is scary.
We have a few minutes for questions, and then we'll have more time at the end. Go ahead, Clement. Yeah.
Thanks, Chris. Really interesting data. So I'm going to preface this by I think like adult CF care has become like pediatric CF care, and pediatric CF care has become like child care. And but I was kind of really struck by kind of your PO antibiotic use in IV, and so I had a question and a speculation. The question is like, how much of that is just done over the phone versus actually seeing patients? Because again, in the pediatric world, right, 60 to 70% of PO antibiotic use is done over the phone. And I'm just wondering whether this, combined with the fact that it seems like the IV antibiotic treated exacerbations are more severe, is that there's like modulators may have mitigated the severity of pulmonary exacerbations, so that when you have a little bit of cough, then you just give PO antibiotics and it takes care of it, and so you have to get pushed harder before you end up, on IVs.
Yeah, that's a great, and I wish I knew. I know anecdotally, I have one of our CF nurses right here, Eric wave. Eric will tell you that we do a lot of phone it in. Mm-hmm. And I'm not against that, but we're a little bit operating in the dark, and we're doing this without evidence that and that's why I sort of praise DB in his study in children, Stop Peds, where they say when you can avoid antibiotics, but also maybe we need more information on how we're prescribing oral antibiotics. Now, you could always say that this is what I showed these slides to Patrick Flume, and he goes, this just says University of Washington are bad doctors, which could be, which very well could be. It's a single center study. There's a single center study, so I don't know. But I do think we're operating a little bit in the dark, and there may be some sense that we should be changing our practice a little bit, getting a little more information, getting lung function. But the nice thing for CF patients is that we are not interfering in their lives like we used to. And that's, I don't know, you have to balance that. It is, I've so many patients told me they just don't feel like they have CF anymore. And if you want to bring that CF back, it's going to be hard, and it's going to be, you better have a good reason for doing that. and again, I just say that adults have really diverse and terrific lives now because of this drug. So I don't know how to do that balance, but I'd like to get some more information. Maybe you guys will show us some at the end of your talk.
Thank you.
Hi, Chris. Eliana Gill from Case Western, also UH Hospital System. I was curious if you guys have patient perspectives on the antibiotics, because I have noticed as a bedside nurse, actually a little bit the opposite in the Cleveland area, that a lot of our adults with CF are very resistant to getting off of antibiotics, which I'm very familiar with your work, so I was very surprised to see this when I moved out there. But I wasn't sure if you guys had any patient perspectives on it.
No, and I think this is what the challenge of a single center study. We are the left coast. We do things differently here. You know, when you go to a stop sign, no one moves forward. We all say, you go forward, you go forward. So I really don't know. There are differences in institutions, and they're quite profound. And with that comes different ideas about patients. I certainly have patients who are uncomfortable, who still want IV antibiotics, but that is not the majority in our center. Most we have a lovely exacerbation intake form, and at the bottom of it is what the patient would like to do. And 95% of the time, they would all like a trial of oral antibiotics to see if they can kick this. And you know, this is what we do. I'm not sure it's the best thing to do, but it's what we do right now. And frankly, if they can do well just with that, I'd rather do that. But I think there are big regional differences also.
Totally. Do you think the increase of antibiotics that we saw is more provider-driven than patient-driven?
I think it's a combination of both. Again, if I was, I think that the move to go back to IVs when you've had, some people have had 2 years, 3 years without an IV course. And if you'd had a lot of them before, you would not want to go back to that. And I think that convincing someone that they need IVs is, you really need to have a good, strong argument that this is what they need. And that's why I think oral, you have to remember, even in STOP 2, 50% of all the patients they were oral antibiotic failures at that time. Again, and that's a national trial. So,
yeah. Thank you.
All right. Time for one more question.
You used FEV1 as the gold standard, and my question is, did you integrate into your investigation also small airway variables, FEF 75, FEF? Second question is, did you stratify or integrate into your study ethnic differences? Because you have a very big number. Yeah.
So I'll take the first question, which I love. So we're looking at all the other parameters in the study for lung function. We have FEF 2575, we have FVC, and we have a paper that we're almost finishing drafting on FVC response, which we've often ignored in CF. So I can't tell you what the FEF 2575 is, but we're looking at it. And I love this second idea, which is, do you have different racial or ethnic differences in response and treatment? We have not tested that hypothesis.
Thank you.
But great question.
Thank you.
All right. Thank you, Chris.
Thanks very much for your attention.
Okay, and then I'll introduce our next speaker, Michael Schechter, is Professor of Pulmonary Medicine, Director of the CF Center, and Director of the Community Asthma Program at Children's Hospital of Richmond, and VCU, and he'll be talking to us about the pediatric perspectives on pulmonary exacerbations in the era of ETI.
Thank you, and thank you to the moderators for having invited me to give this talk. And I'm glad to say that there's only a couple of slides that I have that are similar to what we saw from Chris. So there won't be that much overlap, but a little bit. So I'm very specifically going to take the perspective of before and after ETI. So I don't really have any disclosures that are relevant to this particular talk. So the outline of my talk is basically the old story, and then the new story, and then whatever conclusions I can come up with. So that's basically how we're going to structure this. So first of all, let me just say that over the years, I've sort of become one of the oldest people in the room. So what that means is I get to be a historian. So when we start talking about the old story about what is a pulmonary exacerbation, this actually goes back to the 60s and the 70s of the 20th century. So the idea of just giving pulse courses of systemic IV antibiotics in response to increased signs and symptoms really just emerged as a treatment construct in this country in the 1970s. If you look at the literature and whatever guidelines are being issued in the 1960s and 1970s, they don't even mention pulmonary exacerbation, okay? And in fact, what was really interesting and controversial in the 70s, the 80s, and the 90s was the Danish version of how you took care of cystic fibrosis, which was basically you just admitted patients routinely 3-4 times a year. And the point about that is that they were publishing results in terms of life expectancy, which, like in the 40s, when in the US, the life expectancy was in their 20s. So there are other ways of doing it, but basically the point is that right now when we talk about pulmonary exacerbations, it's really a treatment construct. So here, this, by the way, is an editorial from the Journal of Pediatrics, December 1987. This was actually Bob Wood. This editorial about what is a pulmonary exacerbation. So people were beginning to talk about it, but defining what it was much more of a challenge. And the specific characteristics have been debated ever since. Pulmonary exacerbations are not consistently associated with clear-cut biomarkers like changes in microbial flora, inflammatory markers. They are generally associated with that, but there's no clear-cut cut point because we talk about pulmonary exacerbations as discrete events. But maybe they're not. Maybe they're, as I said, they're just sort of hazy ideas about when do you take the opportunity to treat somebody with antibiotics. And so basically, whether we talk about pulmonary exacerbations as clinicians, or really even when we talk about pulmonary exacerbations in the context of clinical research, the presence of a pulmonary exacerbation is often based upon the judgment of treating physicians. Oh, there's a pulmonary exacerbation because the doctor said so, without there being specific criteria. Again, there have been a number of attempts to create specific criteria. I'm going to talk about that in a little bit, but none of them are really clearly subscribed to by every physician. And the other thing to keep in mind, and this was alluded to a little bit by Chris, but while we usually talk about pulmonary exacerbations, and especially their ramifications and their association with long-term outcomes as requiring treatment with IV antibiotics, we also, especially in pediatrics, a lot of times we talk about pulmonary exacerbations as, oh yeah, we phoned in a prescription for an antibiotic and that was a pulmonary, I'm calling that a pulmonary exacerbation, but that's obviously not the same thing as somebody spending 2 weeks in the hospital. So really, understanding their clinical significance, we need to understand that nobody even really has a good handle on what we're talking about. We do know, and the reason why we decided that pulmonary exacerbations are important is because they're clearly associated in a number of studies using databases like the CF registry and other registries that so pulmonary exacerbations are associated with decreased quality of life, due to symptoms like cough and sputum production. It's associated with decreased lung function, both short-term and long-term decline, and really ultimately also associated with decreased survival. So clearly, whatever these pulmonary exacerbations are, at least historically, they've got some importance based on these other more concrete outcomes. But again, as I said, studies that looked at that relationship with outcomes have focused on clinically diagnosed pulmonary exacerbations that were treated with hospitalization or IV antibiotics. So they're mixing up ones where there were symptoms but no change in lung function, mixing up sometimes IVs with others. So going back to the 1990s, the epidemiologic study of cystic fibrosis, which some of you in the room might remember, was a large-scale study that was sponsored by industry, which picked up on a number of treatment approaches and other clinical sorts of important events that the CF registry at the time was not really following. So there was one publication first that tried to determine what were the clinical characteristics that clinicians used to diagnose a pulmonary exacerbation. And it is divided up by these different four different age groups, conveniently 4 different signs and symptoms. In the under 6, FEV1 wasn't important. It was important later on, but generally increased cough, some changes in pulmonary, physical exam, which again, the ESCF followed as well. So I want you just to see this, and again, these were all the most important associations with exacerbation, but then when they looked, they found that, for example, if we just looked at the kids under 6, only 63% of kids under 6 who had all 4 clinical characteristics that they found were associated were then treated. So this began a realization that there's a lot of pulmonary exacerbations that are going on that maybe aren't really being identified as such and aren't being treated as such. So let's just talk for a moment about how we diagnose pulmonary exacerbations in children. And this is data that actually comes from Indianapolis, courtesy of one of our moderators here, who did a single center study of patients 6 to 17 years of age in 2019, looked at 628 outpatient encounters in 178 children. Most of these patients were not on modulators. Some of them were on the sort of older modulators. Out of this group, 31.7% of the encounters were diagnosed as pulmonary exacerbations. Of the encounters diagnosed as pulmonary exacerbations, 10% had symptoms with a less than 5% change in FEV1. And I did do a little bit of massaging of the data that was reported in that article to give some results here that are a little different from what the article reported. But 10% had symptoms with less than a 5% change in FEV1, so basically symptoms with no significant change in FEV1, and 9% had no symptoms but a greater than 5% change. So there's a fair amount of overlap, but again, there are some patients who have changes in FEV1, and some patients have changes in symptoms. Symptoms led to treatment in greater than 85% of patients who had symptoms independent of whatever their change in FEV1 was. But in those who were asymptomatic with a drop of 5% or more, and who were specifically diagnosed with pulmonary exacerbation, only 61% were treated with antibiotics. So again, I think what's been of real interest to me is the number of events that are potentially diagnosable as pulmonary exacerbation and are left untreated. And then Clement, you mentioned actually the phone. I left this slide in here. You mentioned about, again, another important issue in pediatrics is that a significant proportion of pulmonary exacerbations, or at least antibiotic prescriptions, are done just based on a report of symptoms over the phone. And I think this is important. What do those mean in the long run, in the short run? How do they fit into these other definitions of pulmonary exacerbation? We don't really know. So anyway, but what I want to really hone in on is also due to our inability to agree on a precise definition of pulmonary exacerbation, we see great variation in diagnosis. So this is coming from the Cystic Fibrosis Foundation registry. This is a figure that shows care episodes, which are basically defined in the registry as episodes in which a patient is given IV antibiotics, whether it's outpatient or inpatient, but the key is the IV antibiotics. This is specifically from 2024. You can see the variation. So each one of these vertical blue lines represents the average at an individual care center. And you can see over at the far right, there are some centers that had no pulmonary exacerbations or care episodes in their patients during that year. And then you've got all the way to the left, as many as 25, 30% of their patients had it. So this sort of variation, which by the way, this is post-ETI, we can go back 5 years, we'd see the same degree of variation, except that, as you'll see in a moment, the absolute numbers are much higher. But again, my point here is the variation. And so when we talk about pulmonary exacerbation, which includes all these different signs and symptoms, are we even... Do I mean the same thing as you do when you say it, and do I recognize it in the same way as you do when you see a patient? And the reason this is important, again, this goes back to the ESCF data from 20 years ago now. So first of all, in a paper by Constant using that data, they found when they looked at what was the highest risk factor for decline in FEV1? The most rapid 5-year decline in lung function was seen in children with a baseline of 100% FEV1 percent predicted or greater. So better lung function was associated with more rapid subsequent loss in lung function. Well, then they moved on to another study that was led by Wayne Morgan that showed that high FEV1 baseline was associated with lower likelihood of antibiotic treatment following a decline of 10% or more in FEV1. So what this graphic here is showing is that the x-axis here is baseline FEV1, age-adjusted decline. On the left here, we have the highest patients with the highest lung function. On the right, we have the patients, on the left, we have the patients with the lowest lung function. On the right, we have the patients with the highest lung function. And you can see that your baseline lung function is clearly associated with the likelihood of being treated. So, and then furthermore, another follow-up study, again, showed that just to put the sort of final icing on the cake is that the patients who got treated with antibiotics were more likely to recover to their baseline. So again, this little graphic here shows that hospitalization compared to none, home IV antibiotic compared to none, new inhaled antibiotic compared to none, new oral quinolone compared to none, or any oral antibiotic compared to none, were all associated with a greater likelihood of return to baseline. So again, historically, the kids with the highest lung function were not being recognized or treated, and if they were treated, they would do better. So this is old data. This data now is 25 years old. We repeated a similar study, and I'm going to get into a little bit more detail at the end of my talk because I want to compare before and after. But just to point out that if we look at in 2016 and 2019, overall, the percentage of patients returning to baseline following any kind of acute drop in lung function was in the range of 25 to 30%. This is back to 100% of baseline is what we were using. And this little graphic here shows the odds, adjusted odds of 100% recovery to baseline by treatment. And we broke it down by the decline, starting with a decline as low as 5 to 7%, which is often considered to be within the normal range. But the fact is that you've got a 2 to 4 times fold better likelihood of recovering to baseline with antibiotic treatment, even with a decline of 5 to 7%. And you can see the odds ratio is similar across all of these relative declines. So again, both non-IV and IV antibiotics are more likely to lead to recovery. This is important for the individual, and again, just to show you what the impact is, this is a center practice, so if this goes back to the ESCF and the patients who in the centers that were that had the highest lung function on average of all their patients, they were more likely to treat even 2 signs and symptoms of a pulmonary exacerbation with antibiotics. They were more likely to treat patients with 3 to 4 signs and symptoms with an antibiotic, and they were more likely to treat patients with a drop in FEV1 of 10% or more with an antibiotic. So center practice is associated with better center outcomes. We actually noticed this when I moved to Richmond in 2012. This was from the CF registry, our lung function. The red line was VCU compared to the rest of the country for median predicted FEV1 in patients 6 to 18 years by center. We started the quality improvement project that specifically focused on ensuring that patients with a drop of 5 to 10% FEV1 were given antibiotics. You can see from this run chart that we were successful in changing practice. And then you can see also here that over a 5-year period, we had a dramatic improvement in our lung function. So treatment, the old story, treatment is important. So that was then, and this is now. So just, again, Chris didn't show some of these things. I was wondering if he would. We know that there are changes in inflammatory markers in people with CF who are on ETI. These are some figures from the CF registry that show a drop in recovery of the important pathogens, classical pathogens. On the upper right-hand corner, this is just by year. You can see there's a drop beginning in 2019 in Staph, Pseudomonas, in particular, along with others. If we focus on these lower graphs here, 2018 versus 2023, you can see that, again, the prevalence of Staph, the prevalence of MRSA, the prevalence of Pseudomonas in kids is clearly lower now than it was then. Now, some of that may be the specimens that we're getting, but we're clearly seeing some improvement in antibiotic recovery. This is from the CF registry, again, showing a similar slide to what Chris showed about treatment with IV antibiotics for pulmonary exacerbations. You can see here on the left, this is a drop that affected both adults and children. The green is birth to 11 years. The light blue is 12 to 17, and the dark blue is 18 and above. On the right here, you can see that there was a little bit of a drop in those who were eligible but not modulator prescribed in 2020 that correlated with the COVID epidemic. That's gradually been increasing, but the number of pulmonary exacerbations being treated nationally has stayed at a low level in the patients who are on HEMT. So this is a slide that's similar to what Chris showed about that interview that came from the Hopkins group. Out of the 19 clinicians that they interviewed, 6 of them were pediatricians. So I have some specific quotes from the pediatricians. Okay. So again, pulmonary exacerbations have changed. Quote, for a lot of kids, it's just cough. So overall less severe, tends to get better more quickly. Subtheme, providers are questioning the diagnosis and management. I do sit there thinking, should I give them antibiotics? Is this really an exacerbation? Providers feel less anxious about the outcomes after pulmonary exacerbations. I have less fear that this is not going, about this not getting better. I definitely feel more calm. I'm glad the physicians feel that way. And provider management is less aggressive. I'm definitely willing to wait longer. I think we are seeing a good number of patients get away without antibiotics. Okay. So now let's talk about some other data. So this was an interesting study that was just published in 2025. This is the experience of 5 large pediatric programs in terms of their pulmonary exacerbations amongst their patients. So you can see here on the left, the number of hospitalizations in 2018 for that group was 471, and in 2022 was 163, clearly a big drop. The number of, the percentage of patients with more than 1 hospital or more than 2 hospitalizations in a single year was 45% in 2018 and only 24% in 2022. But when you look at those who were admitted, So their FEV1 baseline was similar. Their FEV1 at admission was similar. But really what's, I think, important is you look at their FEV1 at discharge, and there's really not that much of a change there either. So what starts to come out from this is that while the exacerbations are less frequent, the behavior of the exacerbations may not be that different. Now, again, going back to that study, and I'm running out of time, but I want to go through this quickly, or maybe not that quickly, so I'm going to run over by a minute or two. So again, we had done a study looking at pre-COVID patients on acute drops, looking at the CF registry, establishing a baseline in all the patients in the CF registry, looking for their first drop in lung function from their baseline, which could have been anywhere from 5% up to 50%, and then looking at what happened after that, okay? So in 2016, 2019, this was the distribution of drops, of that initial drop, and you can see that there were a number that were, again, 5.7% were less than 5%. Sorry, less than 5%, meaning they didn't have any exacerbation that we defined. 25% were 5 to 7.5, and so on. Now, I'm just working with Allie Hinton, the statistician, who's been working very hard with me on this. I'm going to show you some data that's new and isn't quite ready for prime time, so we're going to show you some general gestalts and not really focus that much on the specific numbers because we're still working on some of these things. But if you look at the distribution of decline events, you can see in the purple are the patients who didn't have any decline events. For 2020, 2023, those on HEMT were larger, but even no HEMT were higher because I think this includes the 2020 to 2021 period that was post-COVID. So some of our analysis here is tainted by COVID. But you can see that clearly the decline events were less severe when you look at 2020, 2023. Now, let's look at the antibiotic treatments of those acute drops. Now, this is what was going on in 2016 and 2019, and you can see that there were most of the patients who had a drop of 5 to 7.5% were not being treated. 38% of those who had a drop of greater than 15% were still not being treated. So again, it points out the extraordinary lack of antibiotic treatment for significant drops. And again, you can see the stepwise pattern there. Now, if we look at what's been going on now, this is 2020 to 2023. So there are two take-homes here. One is that the same drop in lung function is not being treated nearly as aggressively. Green is no antibiotic treatment. Orange is oral or inhaled antibiotic, and blue is IV. So the point is here, though, that even the non-modulator patients are being treated less aggressively. So this is wearing off even if you believe that there's some invulnerability that the modulator patients have. It's being generalized to those who still are not on modulators. These are some of the predictors of antibiotic treatment currently, which is similar to what we had in 2016 and similar to what the ESCF data showed. Again, the higher your baseline FEV1, the less likely you are to be treated. These are odds ratios across the top of treatment. The greater the decline, the more likely you are to be treated. The patients 6 to 10 were clearly less likely to be treated than the older ones. Those with asthma and Pseudomonas at baseline were a little bit more likely to be treated, and those getting modulators were also significantly less likely to be treated. And then what we're really most interested in working on here is return to baseline. And again, we're going to be working on models that we haven't quite gotten to, but I want to just show you the gestalt here, which is that the percentage returning to baseline by different antibiotic treatment regimen is actually remarkably similar. Okay, so I'm really beginning to look at this and saying, okay, there's a lot less exacerbations, there's a lot less drops, but when they are dropping, they actually do need to be, you need to pay attention. Obviously, you need to pay attention in the ones who aren't even on modulators. So in conclusion, the old story is that pulmonary exacerbations is a poorly defined phenomenon. Clinicians are variable in their diagnosis and response, but are most likely to treat an exacerbation that's manifest as both a drop in FEV1 and an increase in symptoms. The long-term impact of pulmonary exacerbations is probably related to its effect on FEV1 trajectory. And acute drops in FEV1 but not change in symptoms is trackable in CF registries and provides an objective measure for analysis. Antibiotic response to acute drops in FEV1 as low as 5% increases the likelihood of return to previous baseline. And consistent treatment of acute drops in FEV1 is a strategy for preserving lung function. That's the old story. So the new story is HEMT use decreases pulmonary inflammation and reduces the prevalence of classic CF pathogens. HEMT use reduces the incidence of diagnosed pulmonary exacerbations and also reduces the number and magnitude of acute drops in FEV1. Clinicians are clearly becoming complacent regarding acute drops in FEV1 in patients taking ETI, and also in those who aren't. And data seems to suggest that this complacency is misplaced. Stay tuned, we're still working on finishing this analysis, but this is what it looks like. Questions still need to be answered. In children and adults using HEMT, do pulmonary exacerbations impact on long-term FEV1 decline, quality of life, and life expectancy? Do we still have that? Is that still as important as it was in terms of association with long-term outcomes? And for that matter, is there a new relationship between FEV1 and quality of life and life expectancy? These are all things that we need to learn a little bit more. So I apologize, I've used up the question and answer period, so I'm sorry. I just want to acknowledge Allie Hinton, a statistician who did all of this heavy lifting for me here, and Wayne Morgan, who's been involved in all of these discussions. Okay. I apologize.
Let's see. Thank you, Michael. I think if we want to ask one question, we can. Otherwise, we can have everybody back up for the Q&A in just a little bit.
Hi, Dr. Schechter. John Kogan from Seattle Children's. I guess I have a couple thoughts. You probably know that I feel slightly differently about antibiotics. I think we perhaps use too many, and we've had lots of conversations over the year. But anyway, I guess the questions specifically I have for you are just two. One is your thoughts about airway clearance as a treatment for exacerbations. You didn't really comment on that at all. I'm just curious if you guys do that at your center. And then also your thoughts about the STOP-PEDS pilot data, which I think you might remember showed that at least for one exacerbation, up to 70% of kids were able to get by without antibiotic treatment, and just your thoughts about alternative approaches to exacerbation treatment.
Yeah, so I think it all depends on, so as far as point number one is, yes, absolutely, I'm a big supporter of airway clearance, but this is another very subjective intervention, which is actually not really tracked very well in the CF registry anyway. So I'm not really sure how we actually measure the impact of airway clearance. So in the context of these analyses that I've been doing with antibiotic treatment, yes or no, I assume that the patients are doing airway clearance, and I assume that in a lot of cases they're being sent home and saying, do a better job, you know, you better start doing it, you better start doing it more often. And yes, I think that may be helpful, but I'm still finding that antibiotics are twice as helpful. In terms of recovery, yes, there's no question that a lot of patients do recover. A lot of them don't. And in terms of the difference in STOP versus our analysis, again, we're not looking at physician-diagnosed pulmonary exacerbations. We're just looking at changes in FEV1. So there's a lot of variability, and there's no question that built into this, there's a lot of drops that are not that important. But my emphasis is that there are a lot of drops that are important. So.
Thank you.
Thank you so much, Dr. Schechter. And we'll have time at the end for more Q&A for all of the presenters. So now, last but not least, it's my pleasure to bring up Dr. Clement Wren. He is a professor of pediatrics and the Richard B. Johnson Jr. Endowed Chair in Pediatrics at the Perelman School of Medicine and the University of Pennsylvania, and the CF Center Director at the Children's Hospital of Philadelphia.
Great. Thank you. Thank you, Dr. Hergenroder and Dr. Sanders, for inviting me to speak and for all of you to attend. And before I start, Kaylee, I want to personally thank you for your message. And, you know, it's messages like that and hearing from people with CF like you that certainly inspire me personally, but I hope everybody in this room to do all that we can to ultimately cure CF and improve the lives of people with CF in the meantime. And I finished my fellowship in '96. So yes, I saw children being diagnosed with chronic cough and failure to thrive at 10 months, who we now diagnose at 2 weeks of age with newborn screening, and in some cases can even start ivacaftor. And you know, half our inpatient service was CF. Today at the Children's Hospital of Philadelphia, which is kind of a large children's hospital, today we have 0 children in the hospital with CF. So we clearly have a different world, and I'm going to talk about how that might affect how we look at our current approach to chronic therapy versus pulmonary exacerbation. And I'll primarily be talking about a study that we've been doing called HERO2. These are my disclosures. So, as we've heard from Kaylee and we've discussed, ETI has transformed CF outcomes. It results in improved FEV1 and BMI, decreased pulmonary exacerbations, and decreased mortality. These tremendous benefits of ETI have led many people with CF to discontinue chronic daily therapies. What's interesting is that we have plenty of studies now, or plenty of papers published, both single center, multi-center, pharmacy data, that people with CF are taking fewer CDTs. But there's actually surprisingly little data on the effect of de-escalation on clinical outcomes. In fact, I could really only find these 2 studies that I'll talk about. I'm happy during Q&A if people want to cite additional studies. One was by Günther et al. This was a single-center study at Nationwide Hospital, and it really wasn't a de-escalation study per se. It was about the implementation of a de-escalation algorithm. But they did look at FEV1 decline and showed that it was similar between people who discontinued therapies versus those who did not. But again, it wasn't designed to look at that, so they didn't adjust for what are clearly differences, as I'll show you, between people who stop CDTs versus those who do not. And then, of course, there's Simplify, which I think most people are familiar with, was a multi-center randomized controlled trial where either Dornase alpha or hypertonic saline was discontinued. And again, the thing about Simplify, though, was it was a short-term study. They looked at FEV1, and it was stable over those 6 weeks. Now, there was a small sub-study published with only 43 participants who stopped both these medications and were followed for an average of 3.9 months. And again, in that small sub-study, FEV1 and LCI also remained stable. Interestingly, CFQR, which is a measure of respiratory quality of life, actually improved due to decreased treatment burden. So basically, you know, when we started HERO2, there were a lot of knowledge gaps around de-escalation. It'd be helpful to know what the clinical features of people with CF who decide to stop CDTs. And again, as I mentioned, Simplify only gave us a 6-week outcome. So long-term outcome data, such as FEV1 decline, pulmonary exacerbation risk, and more extensive patient-reported outcomes would be helpful. What about the risk factors for pulmonary? So we've looked at pulmonary exacerbation. We know it still occurs in people who are taking ETI, but what are the risk factors for PEX in those people with CF? And finally, there's limited data on people with CF with more advanced lung disease. Mean FEV1% predicted in the Simplify trial was 97, and I think they had 6 participants out of, I think, about 800 total that had an FEV1% predicted under 60. So with that background in mind, HERO2, the objective was to assess the impact of CDT de-escalation on pulmonary outcomes in people with CF taking ETI, and we had the following specific aims. The first, to determine the proportion and clinical features of people with CF taking ETI who have stopped their chronic daily therapies, assess the relationship between stopping these therapies and pulmonary outcomes, and finally, to identify clinical features associated with a stable pulmonary outcome after discontinuation of a chronic therapy. We recently published our study design in Chest Pulmonary last year, but in brief, HERO2 stands for the Home Reported Outcomes Study. It's HERO2 because there was a pilot study called HERO1. This was a prospective observational cohort study that enrolled 860 people with cystic fibrosis, and each person was followed for 12 months. We had very simple inclusion and exclusion criteria. All you had to be was at least 12 years old or older, taking or about to take ETI, and having access to the technology that we used for tracking. And in terms of exclusion criteria, it was recipient of a lung or liver transplant and not being able to use the English language smartphone app because we did not have it available in any other languages. So one of the unique aspects, I think, of HERO2 was that data collection and enrollment were completely decentralized. Data collection was done, that's why we call it the home reported outcome study, because it was done at home through a smartphone app called Folia, and participants then gave permission to link their data to their CFF patient registry data, and we developed, we used what had already been a validated approach towards linkage. Similarly, enrollment and consent were completely decentralized. Informed consent was actually done through the app, so nobody had to come in and sign an informed consent form, and recruitment basically either went through CF centers who then directed participants to a QR-coded link to the Folia app, or secondary recruitment through community platforms such as Facebook, Twitter, and Community Voice. There were also a small percentage of people with CF who were already using Folia because it was a commercial app for self-tracking. So there were some people who were already doing that, and they were approached about participating in the study. This slide outlines the schedule of procedures for HERO2. So if we start up at the top, at enrollment, as I mentioned, we followed people for 12 months. Because we had CFF-PR data, we could also look at their clinical status in the 12 months before enrollment, and we had at least ETI prescription date. It's not exactly the same as start date, but it's usually pretty close. And then through the smartphone app, through the smartphone app, we were able to do daily tracking of treatment, medication use, in other words, and symptoms, the baseline survey, monthly survey, which included PROMIS and CRIS scores, and then an end-of-study survey. We recently published earlier this year by Dr. Hergenroder the baseline characteristics of the HERO2 cohort. So first of all, I mentioned we enrolled 860 participants, but we had data and linkage on 755. So one thing is that a substantial fraction at enrollment had already stopped at least one chronic daily therapy, in fact, 41.5%. You can see that was primarily an adult-aged cohort, although we did have almost a fourth of our participants under the age of 18. There was a clear female predominance, almost 60%. The percentage of people who identified as having white race was higher than actually the national percentage, and the percentage of Hispanic people with CF was actually a little bit lower. Again, mean FEV1 was relatively high, and we had about 4% of people with very low FEV1. CFRD was pretty similar to what you would expect in this age group, and there is a very high prevalence of sinus disease. When we looked at clinical features, that were the only ones that were statistically significant that were associated with CDT discontinuation were private insurance and not having had a pulmonary exacerbation in the preceding year. And overall, insurance, that might be a marker for access or social determinants of health, and the PEX kind of fit with some of the other things, even though they weren't statistically significant. In general, people who stopped a CDT were healthier than the people who had not yet stopped. So this slide summarizes our findings around pulmonary exacerbation risk and FEV1 decline in the group groups that either continued a chronic daily therapy or stopped one. So up here at the top of the table is PEX risk. So if you look at just sort of straight percentage of people who had PEX, it was 16.1 in the people who had continued CDT versus 10.7. In other words, that actually higher in the people who stopped CDT. But as I mentioned, those people with CF were sicker. So we had to adjust for that. And we did that using inverse probability weighted estimator, which is a form of propensity scoring. And so in the next line, we can see the adjusted risk and the risk difference shown in here, which is actually still favors stopping CDT, but if you look at the 95% confidence intervals right below it, you can see they cross the 0 line, so this difference was not statistically significant. Looking at the bottom half of this table, we're looking at unadjusted change in FEV1 in this row, and once again, unadjusted FEV1, again, FEV1 decline was a little bit higher in the people who had continued CDTs. But when we adjusted using our IPW, this difference, again, was not statistically significant. You can see the confidence interval crosses the 0 line. So in other words, there was no statistically significant difference in PEX risk or FEV1 decline in people who stopped CDTs versus those who continued. So again, to summarize those primary findings, a large proportion of HERO2 participants had stopped a CDT at enrollment. Clinical features associated with CDT discontinuation included private insurance and status and no PEX in the preceding 12 months prior to enrollment. And again, CDT continuation is not associated with either an increased risk of pulmonary exacerbation or increased FEV1 decline. And these results suggest that people with CF taking ETI can discontinue CDTs without adverse pulmonary events. I'm trying to keep my presentation shorter, so I don't have time to go into details about some of the additional findings we've had, but we are actually presenting these at the CF conference. So if you want to come tomorrow, I'm going to be talking at a workshop where we looked at PEX risk factors, and I'm going to tell you this, a little bit of it, but I hope you'll still come. It's similar to people with CF, and really the biggest single risk factor for having a pulmonary exacerbation in the year of being in HERO2 was having had one in the year before HERO2. And then we have another interesting analysis led by Brad Rosen looking at whether tracking daily cough, whether we can use cough as a predictor for IV antibiotic pulmonary exacerbations. I'll keep you in suspense so you can go visit Brad's poster. So those are our findings, our key findings, and some of the other things. Like any study, HERO2 definitely has had its limitations. One big limitation is selection bias. I already showed you that we had a gender bias, and again, even though we were hopeful and expected actually that sort of using community-based platforms and decentralized enrollment, we might engage more people with CF that had traditionally not been in clinical research studies, we actually did not have as high a percentage of people with CF from racial and ethnic minority groups as we had hoped. And then just simply by design, we're probably recruiting a group of people with CF who are more engaged in self-care, more engaged in self-health, because we're asking them to track all this stuff every day, and that's just not something that people have to be pretty motivated to do it, even though we're paying them to do it. One of the things we wanted to look at was kind of like intermittent or PRN use of CDTs, and unfortunately just the amount of data that people actually tracked, we aren't able to do that. So we're not able to answer the question of, well, what if you use your Pulmozyme just when you're sick? And again, even though we had tried we didn't have any FEV1 criteria, we still had few participants with advanced lung disease. As I said, we only had 3.8% of people with CF with a percent predicted FEV1 less than 40. I also wanted to just share what lessons we learned through HERO 2. I think one of the positive and important lessons is that decentralized enrollment and data collection are feasible and can provide research quality data. And in particular, merging home patient-reported outcomes with the CFFPR is a powerful tool for research, which is also being used in some other analyses currently ongoing, most notably with the COST CF, which is the financial burden research group, where again people are allowing their survey, the survey respondents are allowing linkage to their registry so that we can actually look at the impact or relationship between financial burden and health outcomes. I think another thing is just these studies take a really long time to finish. We started in we really started in 2020 because we had to plan the study, but enrollment started in 2021, took a year to get us fully enrolled. Of course, the last person that enrolls has to track for another year. So, we were done with the data, the patient-reported outcome data in 2023, but as anybody who's worked with the registry knows, you have to wait like a year to get the data from that year. So we just got that data last year, but then we really still had to go through some cleaning, which really didn't occur till the beginning of this year. So it's taken a very long time for us to get this information, although we do believe that it's been valuable for the general approach towards CDTs. Even with incentives, it was challenging for participants to track every day. So, you saw the dropout that we had, and we built that into our power calculations, but it's just important to keep that in mind. And then, as I mentioned, we didn't recruit as many people from racial and ethnic minority groups as we would have liked to, so we're probably going to need different strategies to recruit a diverse study population. I did also want people to be aware of a few other de-escalation studies that are in progress. In particular, CF Storm, led by Kevin Southern and Gwyneth Davies, is a United Kingdom RCT of Dornase alpha or hypertonic saline discontinuation, but for 12 months. They are actually presenting their preliminary results this Saturday at a workshop, so I definitely encourage you to go to that if you want to learn more about this topic. NEMO is another UK-based study, which is a registry-based observational cohort study. It's a 5-year study, though, focused on adherence, but of course, related to that would be clinical outcomes associated with discontinuation of chronic therapies. And finally, sometime next year will be REACT, led by Felix Ratjen and Margaret Rosenfeld. This is a US RCT, again, of Dornase alpha or hypertonic discontinuation, in this time in children, for 12 months. And they're going to be following both FEV1 and LCI. So in summary, there's strong interest in CDT de-escalation in people with CF taking ETI, and in fact, many people with CF have already stopped one or more chronic daily therapy. HERO 2 adds to the body of evidence that people with CF taking ETI can safely stop chronic daily therapies. However, as I said, I'll show tomorrow that people with a history of PEX remain at high risk for future PEX. And I think it's also really important to remember that we have limited data on people with CF with very low FEV1s, such as 40% predicted. And then I just showed you in the previous slide that along with HERO 2, we're going to have these future studies that will add to our knowledge of de-escalation. And so I think in the very near future, these results will aid in shared decision-making around CDT use in people with CF taking ETI. So in closing, I want to acknowledge our funding through the CF Foundation and the HERO 2 study team, in particular, Cindy Brown at Indiana University, my co-principal investigator, and Kevin Soder, who really did all the work of all the statistical analysis, all the people who contribute data to the CFFPR, and our HERO 2 community project team members who helped design the study. Thank you again, and I can take a few questions.
Great, thanks so much, Dr. Wren. While we're waiting for people to come up to the microphone, we had a couple questions come in on the app. So the first question was about discontinuation of chronic daily therapies. Was it completely discontinuing all therapies or just one of the therapies, such as Dornase?
Yeah. So again, so those 41.5% patients had just reported that they had stopped at least one chronic daily therapy, and it was really the entire range. It could have been airway clearance, Dornase alpha, hypertonic saline, and the majority had stopped just one of them. But we definitely had people who stopped 2, 3, or even 4 chronic therapies.
Hi, Jennifer Logan from Lehigh Valley. Hey, Clement, thanks. So my question is, you extrapolated with each separate type of CDT and if they stopped one, but did you, or can you look at people who went from twice a day to once a day? Because clinically, most of my patients, like, they would just prefer to go to once a day.
Yeah, so no, we didn't. We could, because the registry does collect different dosing methods, but for the purposes of this analysis, stopped CDT really meant that. They just stopped, for example, their pulmozyme.
Actually, we can actually head into the Q&A portion. We want to have the other speakers come back up to the podium. Okay. Looks like there's another question while they're doing that for Clement. Is anyone looking at discontinuation of airway clearance or CPT?
Well, it is one of the CDTs that so that's why we call them therapies and not medications. So, you start getting into kind of small numbers, but we can look at that. The other study, like NEMO, is looking at airway clearance discontinuation.
All right. Thank you so much again, Dr. Wren. Okay, so now we wanted to open the floor up for you all to ask questions for all of our presenters. And I see actually someone at the mic already, so welcome.
Well, I was going to ask the previous speaker, but this is for the whole group. We have this. I'm a Jay Dandekar from the University of Washington. We have several patients in our clinic who have spontaneously stopped inhaled antibiotics, which, as far as I know, haven't been included in most of these studies. I was wondering if there are any data about discontinuation of inhaled antibiotics for people who are eligible for those therapies.
Yeah, so that is one of the ones that, we tracked. So again, we haven't done, those are some of the sub-analyses we could do, is look, and as you know, a lot of people who are PA positive have converted to PA negative. So, but yes, one of the therapies that was listed as discontinued was an inhaled antibiotic.
And I think there is a study, well, there's a practice going out there in Ireland. I don't think Barry Plant is here. I'm looking out in the audience. But I think before they elect to stop inhaled antibiotics on their patients after Kaftrio or ETI, they actually do bronchoscopy if they are not expectorating. So they're not comfortable. I think it's just the wild, wild west of what practitioners are doing.
That actually leads to part of my question. It's Matt Hazen from Atlanta. Hi, everybody. I'm sure a lot of you guys have walked in the room and had a parent just tell you they just stopped. They take their ETI, but everything else they've just stopped. And so we in Atlanta are trying to take a stepwise approach, some sort of practice-wide approach to this. But I'm curious to see what folks are doing in terms of this, because I imagine some people, some parents would see this and be like, great, stop everything.
So this is open to question on what you do.
Yes. No, you guys, I'm already.
Well, in the adult center, I'd have to say that it's not a question of parents being involved. It's often the patient saying, I'm stopping, and it's pretty clear. So, and if we have been reintroducing therapies stepwise in patients who have declined after stopping therapy. And we've even done the same with reintroducing it and actually checking lung function in a couple of weeks just to prove to the patient either working or not working. So that is something we're doing as a practice. It's not regimented. There are 5 of us. Dr. Danikar, who's just up there, was one of us. But generally, that's what we're doing. And again, adults have strong opinions about their care. And if I had CF, I'd have strong opinions about my care. So it's really not but I think it's very different in the pediatric realm. But I'd love to hear what my colleagues say.
Yeah, so right, it's really different in pediatrics and adults because our mothers are much easier to convince to do things than the patients. But I think that still, I think you're a pediatrician, I'm a pediatrician, we certainly get a lot of patients who come in and their families coming in, they're not doing it. And I think that there's enough data for a discussion about pros and cons and what we do know and what we don't know. And I think that when you really come down to what I do, it's like say, okay, if you don't want to do it, that's fine. But when you develop a URI, when you develop any increased signs and symptoms, then that's the time to reinstate it. And that's, I think, something that makes sense to most people. And unfortunately, it's a difficult intervention to measure in some of the outcomes studies that have been done, but I think that's really important. I think stopping when people are well, but then reinstating it when they're having symptoms, and I haven't been very successful. We, around COVID, basically all of our patients ended up with home spirometers, and unfortunately, a shockingly few number continuing to do it even when we ask them to, but that would be ideal as well. But I think that, again, in terms of working with co-production, as we talk about, I think you got to work on coming up with a solution that's reasonable. And clearly, even though I really still feel like aggressive treatment of exacerbations and aggressive treatment of acute drops in lung function is important, we also recognize, and the data shows that for most patients, they're not having that. And so if they're not going to have a problem, then they do pretty well without doing how they want to do it.
So our next question from the app is for Kaylee, and it's, how do you negotiate health insurance coverage and work-health balance?
This has become really interesting in the last couple months for me because I've recently decided to go back to school, as I mentioned. So I quit my full-time job. I was a software developer for 7 years, had steady health insurance through that, but just really decided to throw a wrench in things by changing my plans up. But I'm working 20 hours a week right now, just a part-time job, enough to get health insurance. And it's working fine for me. I'm able to, balance that, but I think it's a very patient-specific question. No one's gonna, have the same answer that I do necessarily. So, yeah.
There's another question from the app for Chris. It was regarding the slide that showed that the decline in FEV1 greater than 10% predicted was there's a higher proportion of STOP 360 participants than the STOP 2 participants, and they were wondering what we think that might be about, and in question were patients maybe stopping their Trikafta and that was accounting for the larger loss of lung function.
Yeah, I would say I don't think it's from stopping Trikafta, although there are patients in that study that have run out of some would argue that one kind of exacerbation or phenotype is the loss of insurance and the loss of Trikafta. And then coming in with an acute drop in lung function, as Michael has noted, you could easily fulfill the criteria for an exacerbation without Trikafta, without medications, and come in and then needed to be reinstated. And most of those patients, at least in our practice, will end up with IV antibiotics because we're concerned with the drop of lung function. So we do have that data. It's not been looked at. We have those con meds when patients are enrolled in the study, so we'll be able to tell. I actually, clinically, I think patients are there. It's, I think it probably has to do with sort of the impetus for starting IVs. I think the threshold to start IVs in a adult clinic has really gone up. You have to be sicker and have more symptoms to actually be able to convince that IV antibiotics are the correct course. So I think things have changed. I think they're very dynamic. We'll learn a lot when that study's done. And we'll learn whether the phenotypes of exacerbation have indeed, I think they are changing, and this will hopefully be able to continue to do these analysis periodically and compare those enrolled that those are not enrolled. The study hopes to enroll 750 patients, so we're only at 304 right now, so hopefully we'll be able to answer some of those questions.
Dr. Schechter, one thing that stood out to me in your talk was that compared to pre-modulators, the same drop in FEV1 is not being treated quite as aggressively now, but you noted that trend even for people who were not on modulators. And I was curious your perspective and others on why you think that might be.
We were just having a conversation about that this morning. And Wayne was mentioning that his team notices that they're clearly not treating the patients who are not on modulators as much as they were treating before. So this is what I was saying, is that there seems to be some generalization of complacency that spills over to the non-modulator patients. I think we need to be really careful to look for that and watch for that.
Also for Dr. Schechter, can you talk more about complications and risks of a low threshold for antibiotics? For example, will more courses of oral antibiotics increase risk of multi-drug resistant organisms? Any thoughts on using inhaled antibiotics rather than oral?
So that's a long story, we did a survey. I was involved with the benchmarking project with the CF Foundation now 20 years ago, something like that, and that was one of the places where I noticed that what distinguished the centers that had the best lung function that we were visiting from others seemed to be more frequent use of antibiotics. We've sent a survey around to all the CF center directors following that. And one of the questions in the center, one of the questions in the questionnaire was, how much do you worry about antibiotic resistance? And a response that the physician was more concerned about antibiotic resistance was clearly associated with worse lung function on average of the patients at their center. So I think that there's no question that there are issues around antibiotic resistance, but I think that at least, and maybe since I'm a pediatrician, I don't have to worry about what's going on when they go into the adult center. But as a pediatrician, I don't have a big problem with drug resistance. I have a much bigger problem with my patients who are dropping their lung function. So I think that, there's no question that drug resistance is something that's a consideration, but I think that, again, historically at least, that drop in lung function was really the most important thing. And I do think that it's open to question in the post-ETI world whether that drop in those acute drops in lung function, or even maintaining lung function as high as possible, is the highest priority given all of the other trade-offs in terms of detracting from quality of life, in terms of hospitalizations, in terms of all the antibiotics and so on. I mean, I think that's a reasonable question. In my mind, in the pre-ETI world, and in the patients with CF who are still living in the pre-ETI world, that's not a hard question. I mean, I think they need antibiotics, but in post-ETI, all of those priorities, I think, need to be re-examined in terms of long-term outcomes.
Mohammed Almiri from pediatric pulmonologist from Orlando. I have a question for Dr. Schechter also about the drop of FEV1. I noticed the age is between 6 to 40, which I think that's a big group. And since I'm pediatrics, I'm interested to know if you look closer in patients, let's say 6 to 12 or 12 to 18. And did you notice the same trend? We're assuming that the lung damage or the severity has not reached to the level of someone else. So I was just wondering if you looked closer at that age group in pediatrics. Thank you.
Yes, so we didn't do it in the analysis that we published with the pre-ETI patients, but it's something that I'm definitely interested in doing in this analysis that's really ongoing. We're sort of mid-analysis right now, so there's still a lot of things that need to be, worked through. But I think that it is of interest to see the difference in what's going on in pediatrics as opposed to adults in terms of that return to baseline. Yep.
Thank you.
Dick Simon, University of Michigan. Soon after Dornase Alpha was approved, there was a subsequent trial of patients beginning Pulmozyme at the time of a pulmonary exacerbation. It was randomized, I believe blinded, large study. Short-term outcome was no different. So I bring this up with the idea that you would begin at least Pulmozyme, PRN, for a pulmonary exacerbation. Is it that we don't think that data still is accurate, or what do people think about this idea of PRN at a time of an exacerbation?
Yeah, I think we haven't been doing that again in our practice, but we're sort of in an evidence-free zone, which physicians love to practice in. Patients don't always like that, but we have been augmenting care rarely. Often hypertonic saline is our first. The reality is in adult population, getting these drugs approved takes our nurses and our pharmacists. Like SNAP approval of inhaled Toby is not happening. SNAP approval of Caistin is not happening. So it's really not. It can't be really a big part of adult care just administratively. But hypertonic saline is easily available, so we have done that, and logically it may help. Again, I think the answer is we don't know. I think one of the big challenges in Pulmozyme in general is we just don't know if it works that well in this population because of the lack of thick secretions. Its whole biologic premise of thick secretions with the high levels of DNA that's sticky. And so I do think a lot of the things we think about in the past, I don't know how well they apply to the current state.
Hi there, Chris Calkins here. I'm an adult pulmonary fellow at Stanford. Thank you all, in particular, Kaylee, for sharing your story. In my fairly limited experience, a big barrier for the desire to move to IVs is really the requirement for hospital admission that is often involved to get workup done, line placed, antibiotics going. I was just curious if any of you have had experience outside of maybe patients who have a port in place with actually establishing IV access and starting IV therapy with the patient in the outpatient setting, just because that's sort of what I've seen thus far.
I'll probably tackle that because we're left of left. So our hospital is a surgical hospital, so they love surgical admissions. They hate medicine admissions, and they make it very difficult for us. And because of that, I think our practice patterns have changed. We very commonly have a PICC line placed in an outpatient setting and start a first dose of an antibiotic in our infusion center, and they go home on it. Even though all the evidence suggests they'll do worse as just outpatient alone, but it's both patients don't like being in the hospital, some know they would like to be in, and we can get them in, but it is very difficult in the economics of adult hospitals, particularly these large quaternary centers, to get a bed in the setting of where pediatrics are. The RVUs, the bed reimbursement rates for a 2-week hospitalization in a major center when they could do, 5 abdominal surgeries for that same bed. The math of the hospital administrators will say you will become a thorn in their side really quickly. We can still do it, but it takes begging. So that practice works. It's quite safe, particularly if people have had the antibiotics before. And even those who are hospitalized, we have a hard time keeping them for a whole course. They will be calling us every day after 24 hours to say, are they ready to go? Are they ready to go? And even folks who cannot take IV antibiotics at home, and you have to answer them pretty much daily to say, no, this patient really needs to be in the hospital. Because they all look so much healthier than everyone else on a medicine ward in the current environment. So I think they're sort of what is ideal versus what is realistic. But it can be done. The outcomes are probably not as good, but we've been doing that for 15 years.
As a brief follow-up, what's like the typical turnaround for you in terms of you have a patient in clinic, you decide you want to treat, how quickly can they get started?
Anywhere from 24 to 72 hours. So if you think they need it immediately, we send them to the ER. They can't send them out of the ER, they will admit them all from the ER. If we send them to the ER, they will get admitted. It'll just be 24 hours later that they ask you if they're ready to go home, even if they're really not.
Thank you.
So just to add the pediatric perspective, I mean, we've had data actually from the epidemiologic study of cystic fibrosis going back 20 years that showed clear benefits of hospital stay versus outpatient antibiotic treatment. It was a more noticeable trend in kids than it was in adults. But even so, there are some who do okay. And so, again, if you have a family that really wants to do it, and they show that they can do it. So, again, once they have a history, if you've tried it once, and you do your home IV therapy and they return to baseline or as close to baseline as you're hoping that they were going to get, then that family has shown that they can do it. And then you have others that clearly show that they can't, and then you're not going to give them the opportunity to try again. So I think, again, a lot of this stuff can be individualized. And outpatient medicine is wonderful because we have all these second chances, I mean, it's okay, well, we'll try it for a week, and if it doesn't work, then we'll admit you then, or, that sort of thing. So there's lots of fine-tuning that you can do with individual patients.
So our last questions are for Kaylee. So have you stopped any chronic daily therapies since being on modulator therapy? And what has been your approach with your CF team?
Yes. I've been a little all over the place. Now I'm back to what I did prior to Trikafta, which is daily Pulmozyme. Every now and then hypertonic saline. I don't do it as regularly as I used to. And twice daily vest. So pretty much back to what I did prior. But I have experimented with like taking, extended breaks on certain things just because I felt so tremendously different after starting Trikafta that I just felt like, okay, if I'm going to have a chance, this is it. So I just kind of, would do, I don't know, a month here, a month there, just kind of like trial and see how I felt. And hypertonic saline, I kind of felt for a long time that that's the only one that, it's hard to say, but I almost feel like it just causes more irritation than I get benefit from it. So that's the one that I've kind of permanently pumped the brakes on, at least not unless I'm feeling super, super junky or something like that. But as far as Pulmozyme and vest and things go, my routine's pretty much the same. Yeah.
And what went into your decision-making to switch from Trikafta over to a left trek?
Yeah, so I'm currently on a left trek. We had sort of noticed the first, 2 years or so being on Trikafta just did phenomenally. I mean, compared to, pre-Trikafta, I was just like a completely different person. Just such a reduction in cough and sputum and, weight gain was great, all of that stuff that I mentioned before. But after a few years, I did notice sort of some slight backslide, I would almost say. It wasn't terribly noticeable, but I did start to notice a resurgence of cough and sputum production and things like this. And starting to feel like I needed antibiotics a little bit more, whether that was oral or IV. So we kind of made the decision to switch over to a Liftrec and just see if it happened to make a difference for me. And I think we've kind of arrived at the conclusion, I say we, my care team and I and my parents and everybody, that it doesn't seem to have been kind of the home run that Trikafta was. And it's not really like that fair of a comparison, just given how sick I was pre-Trikafta and how well I did post-Trikafta. It was, it's gonna be hard to live up to that. But I didn't notice a big enough difference, a positive difference starting on the Liftrec. And in fact, feel like I actually had a slight increase in like shortness of breath and things like that. And I'm kind of a theme of my whole, talk today and everything. Everyone's different, right? Like I'm just one person, but that's been my experience so far. So we made the jump just to see how it would go, hoping for the best, but just didn't really see that much of an improvement. So decided to go back to Trikafta. So, yes.
Okay. I just want to say thank you to all of our speakers today, and thanks to the audience for joining us. I think we'll end our session here and enjoy the rest of your conference. Thanks.